Now we'll talk about how do we sequence treatment in the future in the EV302 era. These are my disclosures. So prior to EV302 reading out at ESMO last year, this was the general paradigm I think most of us were following. For cisplatin-eligible patients, we would offer cisplatin-based chemo. If they progressed, they would get immunotherapy. Pembrolizumab was the level 1 indication. Erdafitinib if they had FGFR alterations, and then if they progressed, and here obviously I should add EV along with erdafitinib, and then sacituzumab was available to us as an expedited approval based on the trophy study. And for cisplatin-ineligible patients, gem-carbo was an option, followed by velumab maintenance, but also EV-pembro was an option for us. And for truly platinum-ineligible patients, we were using single-agent pembrolizumab, and then depending on their mutation status in the tumor, erdafitinib was an option. So talking about the trophy UO1 cohort 1, this was the study that initially got sacituzumab approved in the post-platinum, post-IO setting. And we also know now that this has been withdrawn. This was just presented, I think, today by Petros at ESMO Asia, so I could not get those slides. But the phase 3 trial, TROPiCS-04, which compared sacituzumab to dealer's choice chemotherapy like docetaxel or vinflunine, was not only negative in terms of efficacy, but there were more toxic deaths from sacituzumab on the study. And Gilead has pulled this drug from the bladder indication. We have another exciting ADC targeting the HER2, new in this pan-tumor Destiny trial. We saw that in the bladder cohort for patients whose tumors expressed HER2 at 3+ on IHC, they had the median PFS was around 7 months for those patients, and median overall survival was also pretty impressive at 12 months. And there was some benefit seen in even those expressing it at a lower level. So this is also an option available for us. It is a pan-tumor approval, so we are trying to look for IHC for our patients with metastatic disease. And the IHC is not based on the breast, but it's based on how the gastric tumor was stained. I know Arlene will talk about erdafitinib in detail, but this is just the TOR trial that I wanted to highlight how it has impacted the sequencing. In the cohort 1, we know that erdafitinib is better than chemotherapy in terms of overall survival, statistically significant, and if patients have FGFR alterations, this is the standard of care. But in the sequencing question of erdafitinib versus pembro, and I know this morning we were discussing that hypothetically, patients who have tumors that are FGFR expressing, they may be resistant to immunotherapy, but that theory has been debunked, I think. In this phase 3 trial, we saw that it was not better than pembro, and so the sequence should be pembro first and then erdafitinib. So I think the current treatment paradigm for us would be, you have EV-pembro, which is if it's the right thing for the patient, and it's available, that's what we should use. If the patient progresses, then platinum is the next best option, and that's what I'm doing in my practice, because even in the EV302 study, patients who progressed had platinums had about 30% responses. And of course, clinical trial is an unmet need in this space, especially because EV-pembro, if it moves early on, then we will be left with this big question of what to do in the metastatic setting. And if patients progress on that, then erdafitinib if they are eligible, and TDXD if they have HER2-positive tumors. And if we are not using EV-pembro, then platinum followed by velumab or gemcis nivolumab for cisplatin-eligible patients is also an option. I think in the rest of the world, this will still be used widely. And if patients progress, then EV, erdafitinib, or TDXD. And I think also for platinum or EV-ineligible patients, we'll have pembrolizumab followed by erdafitinib or TDXD. So I really don't have a lot of slides because we don't have a lot of data in this space. So I'll give back a lot of time for discussion. But in conclusion, EV-pembro is the preferred frontline option when available and accessible. I think platinums certainly have a role in the metastatic setting, and they're not really done in this space, and we need to have trials which can actually beat the 30% efficacy, and we need to have prospective data in this setting. We should be doing genomic testing and IHC testing for subsequent therapy decision, and really develop trials which are forward-looking and not trying to, I know there's a lot of trials looking at, intensifying the EV pembro benefit, but I don't think that's where we need to look at. We need to look at what to do next. And also, patients who progress on EV pembro really don't do well for the most part, and we need to do some really good trials and drug development for those patients. Thank you.